Good morning, everyone, and welcome back to yet another lockdown Zoom session with Ivodent. This morning, we are fortunate enough to have well-known Jeffreys Bay dentist, Dr. Evert Burger from J Bay Dental Studio, also the founder and brain behind the Composite Club. Guys, this is only a teaser lecture. Evert is running phenomenal 2 to 3 day hands-on courses with the main focus being full mouth rehabilitations with composite. Don't forget about the fun-filled activities planned around the academic program. And then I'm not even mentioning his dentist wife Carmen's chef skills to keep everyone fueled. Be sure to follow him on all his social media platforms to share in his passion for dentistry and life in general. Evert, baie dankie vir jou tyd. Dit is 'n voorreg om jou hier te hê vanoggend en ons sien baie uit om te luister na jou lesing. Before we start, just a few house rules. If you hover around at the right-hand top side of your screen, you'll be able to select between speaker view and gallery view. Please select speaker view, as Evert's presentation slides will then appear on full screen on your side. Please mute and turn your videos off. If you've got any questions during the lecture, you're more than welcome to pop it into the chat box. If you hover at the bottom of your screen in the middle, a small chat icon will appear. If you click on that, you can pop your questions in there. Evert has also indicated that during his presentation, he has allowed for questions. If you would like to ask a question, please unmute yourself and put your video on and take part in the discussion. The lecture is being recorded and will be made available on all Ivodent social media platforms, as well as on our Ivodent online YouTube channel. We look forward to listening to you, Evert. Baie dankie, oor na jou.
Hi, Stephne. Thanks so much for the nice introduction. I don't know how well known I am. After you putting that post out, all my friends have been giving me stick about being well known. So I don't think I'm that well known. Thanks for the introduction. And thanks everyone for joining us. I'm gonna introduce you to the Composite Club, and I want to talk to you what I'm doing on a daily basis. I think the big thing about me, that if you don't know me, the big thing about me is I'm not a very academic dentist. I'm a very hands-on dentist. I like to work with my hands and I like to get my hands dirty. And I think the important thing is I'm not going to try and teach you guys a bunch of skills that you can't apply every day. So the important thing for me is if we do something or if you learn something, you need to be able to use it the next day. And that's why I started the Composite Club. But before I started the Composite Club, I'm part of a group called the Dental Study Group 2. And you can see the photo on the right-hand side. There is a photo of the Study Group 2. And I've learned more in the study group than I've learned anywhere else in the world. And the amazing thing about the study group is we're a bunch of friends. We get together 4 times a year and we have fun. We drink some wine together. We braai together. We eat together. And then we spend the weekend talking about teeth and talking about dentistry, and we talk about life in general. So what I wanted to do with the Composite Club is to create a similar kind of thing where we get together and learn about dentistry, but also enjoy a meal, go out on the boat and spend some time. And that was photos from the first, I call it Composite on the Crom lecture we did. On the Crom River in the Eastern Cape, we were about 15 people and we had a nice weekend eating good food. Like Stephne said, my wife's an amazing cook, so she made amazing food for us. Why my slide like that? Anyway, amazing food for us, and we learned about dentistry. We drank good wine, and that's the idea is to not just teach people about composite, but also learn from other people, and also get together and have fun and get to know people on a personal level. So that's the idea about the Composite Club. Also, we want to talk and teach people to do full mouth rehabs and full mouth reconstructions using composite only. And I'll get into the details why I love composite so much. But this is a case, and I want to show this. It's a case I did about probably 4 years ago, and that's like my canary down the mine case. You can see everything about this case is not great. It's a very average looking case. But the guy couldn't afford anything else, and we had to use ways of restoring his teeth, and that was affordable for him. And in this case, composite was the only thing he could afford. So in this case, we didn't do any crown lengthenings or anything. We just stuck composite on the teeth, so we bonded it together. And that was about 4 years ago, and I follow this case quite keenly to see all the complications we get. And so far, we've got no complications. And it just shows you that even in a severe wear case like this, you can use composite, which is known to be a softer or a weaker material. You can use it quite well to restore full mouth cases. And that's why I want to teach people and want to learn with people to do these bigger cases in the Composite Club. So you're going to ask me why composite, and I can give you the obvious 3 things. It's I can give you the obvious things. It's minimally invasive, it's affordable, it's repairable, but that's not what it's all about. There's way more to it, and I want to take you back to 2007. And probably one of the most important things in the world happened in 2007. That's when Steve Jobs launched the iPhone. And about 2007 as well, Facebook from Mark Zuckerberg became very popular. And in 2010, Kevin Systrom formed Instagram, which was subsequently bought over by Facebook for $1 billion, which was probably the biggest bargain they ever bought. And since then, we've all been stuck to our screens. You're probably watching this on your phone screen, wherever you are. Whether we're in the bathroom or in the restaurant or in the gym, we're stuck to our screens, and we're mainly doing a few things, and that's Facebook and Instagram. And what we also do during lockdown is we spend a lot of time on Netflix. And when I watch my favorite series, Narcos, I don't want to watch one series. I watch the whole series. I can't just watch one program and wait for it for another week for the second one. And we used to having things on demand. We used to having a phone in our hand. If we want something, we click it and we get it immediately. Like I watched the whole Narcos 3 seasons in 2 or 3 days. And that's something all of us are used to, and all of our patients are used to as well. And then while we're doing and watching our Netflix, on our phone, we're scrolling and we're seeing all these programs that's made popular. Stuff like Mooi Maak, Braak My Mooi. We see advertising from various dentists, and all of this our patients see as well, and they're getting used to the fact that all these programs advertise immediate results and immediate satisfaction, and they're used to having immediate results from the phone as well. So we need to offer them something that's immediate. And you're going to ask me, what does Netflix and Facebook and Instagram have to do with composite? But composite is the material that gives us all these options. I just want to look at that video quickly. You can't hear the sound, but what this lady is saying is like money, which is I don't look like my mother anymore. And the important thing about that is there's a few things that video shows us. The first thing is our patients are getting older and older, and they need to be treated minimally invasive. This lady is probably in her 60s. She's probably going to be around for another 30 or 40 years, and her mom is still alive, so genetically she's probably going to be alive for a long time. So we need to give her a treatment option that's very minimally invasive. The second thing that's important is our patients are getting have less and less disposable income, especially after this time with the coronavirus. People are not going to want to spend a lot of money on dental care. So we need to give them an affordable option when restoring the teeth. And then thirdly, like I mentioned, our patients want to have immediate satisfaction and immediate results. And composite is the one material that tick all those boxes. And that's why I love doing composite. And in the beginning, I used to do composite as a temporary kind of material. And we're going to get into treatment plan now, but it's like a phasing material. When patients couldn't afford other treatment, I said, let's do a composite alternative. And the more I do it, the more I realize that it's not maybe an alternative, it's maybe actually a long-term option that's going to last very long. So I've been doing these composite rehabs for the past 5 years, and I'm always amazed at the long-term results I get and the long-term stability of these composites. So I think we all should change our mind slightly about what is composite, and you can use composite in a way bigger setting than just a little filling or a little class 4 or a little class 2. We can use the material there's a bigger spectrum of treatment choices we can give our patients when we stick to composite. We're going to go on to the first part, and that's called the treatment planning, and how I treatment plan all my patients. Is there any questions so far? I'm sure there's nothing. So we're going to go straight in. If there's a question, please pop your hand up or let us know in the chat box. And Steph, now you can just stop me. But when I treatment plan all my patients, I stick to the less is more approach. And this approach is made, is a paper written by Riccardo Mitrani in September 2019. He wrote it for the Spear Education website. And whenever I see a patient, I take this article, I open it up next to me, and I go through this article and make sure I follow this step by step when treatment planning. And when the highlights of this, the less is more approach, or the 5 elements of the less is more approach, is the following. It's maintain the most tooth structure. Sorry. Minimize the amount of teeth involved. Utilize the least invasive way or techniques. Delay treatment and phase treatment. So those 5 steps I always keep next to me, and I follow when I treatment plan my patients. So I'm going to show you the case we're going to discuss today. It's about a 41-year-old male. He's completely healthy. He could afford good dental care. He came to me for aesthetic purposes. He wanted to get his teeth looking better and looking whiter. And like all other patients, or all male patients, he was referred to by his wife. A male patient never makes the appointment. It's always his wife who makes the appointment. And she also found me using Instagram and Facebook. And I think that's very important for how we market ourselves and how we get our names out there. Is we need to take in consideration those platforms, because that's where people spend a lot of time. And like I said, so this patient saw some of the work we did on Facebook, and then they contacted us and asked for basically an aesthetic opinion. We looked at all the teeth, and you can see all the caries, lesions, all the wear facets. So I said to the patient, we can't just fix your front teeth. We need to basically do a full rehab for you, get your bite right, and sort out all the decay. So then we went on to treatment planning. And like I said, the goal we have is to maintain tooth structure, minimize the amount of teeth we involve, utilize the least invasive techniques, delay treatment, and phase treatment. So in this case, the treatment plan we proposed was to do a bleaching first of all, to restore all the decayed teeth, to open the vertical dimension, to do anterior composite veneers, to restore the aesthetics, and then to give a Michigan splint to make sure our work lasts as long as possible. And you can see when you look at that treatment plan, it kind of ticks all the boxes that we spoke to. I'm sure if you take this case and you do minimally preps and you do porcelain veneers and porcelain overlays, you're going to be able to present this case as a very good case. And there's nothing wrong with going the porcelain route. But like I said, this is a very young patient, so I like to be as minimally invasive as possible. And using composite just makes it so I can be even less invasive than doing minimal preps for porcelain. So I just want to talk about that delaying treatment for 1 second. I always tell my patients that I treat like this. I say, we're going to use composite all over, but we might have to redo 1 or 2 teeth using maybe a porcelain if the composite keeps on giving us problems. So I kind of tell them we're delaying treatment for as long as possible. I think we always have to remember that no matter what treatment we do, it's not a once-off treatment. We're not doing treatment now and we're never going to see that patient again. I've been in the same practice for about 12 years now, and I see my stuff that I did, the crowns I prepped 12 years ago, I see them failing, and I see bridges failing. So now I know I need to be as minimally invasive as possible, and I need to tell the patient that, listen, something might go wrong. We might see you again in a year or two's time, and we might then do a porcelain or do a crown. But for now, let's do the minimally invasive way, and let's see how it goes. And like I mentioned, I'm always surprised how long these things last. The complications you get are always minimal and always small, and you can always either polish it out or add on to it. And once again, that's why I love composite. So that's how I treatment plan all my patients. Always keep the long term in mind. If you're going to stay in the same practice for 20, 30, 40 years, you need to know that you're going to see those people. The other thing I always see is we live in Jeffreys Bay, so we've got an older community, and we see all these crown preps and big rehabs that was done in porcelain maybe 20, 25 years ago, and now they're all failing. And the patient is 75 or 80 years old, and they can't afford to get these things redone. So I think it's very important for us to be responsible in the way we treat our patients. Always do minimal work that's going to last. Always stay in enamel and make sure our work lasts as long as possible, or the natural tooth lives as long as possible. So that's why composite is really a nice way for me to treat patients and make sure we're working minimally invasive. Right, so the next phase that we're going to go on to is the 7 stages of restoring teeth with composite. Is there any questions maybe now? Anyone want to add something or ask something? Are there any questions, Stephanie? It looks like in the... Okay, nothing. Right, then the next step we're going to go on to is the seven stages of restoring teeth with composite. And this is very important because we need to follow these steps very good to get long-term results. If we're going to take shortcuts in doing our composite restorations, we're going to get them to fail. And these 7 stages we need to keep in the back of our mind when doing composite restorations. So the first one is isolation, access, and clinical control. The second one is caries and disease-free. Then it's preparation of the cavity, the matrix choice and adaptation, conditioning of the teeth, composite placement, and occlusal anatomy and polishing. So let's look into them a little bit more deeper and talk about them a little bit. These 3 steps are the critical steps. And what I mean with critical steps, I mean they're probably going to last, your filling or your restoration probably won't last a year if you don't follow these steps. So these are the very important ones. The first one is isolation, access, and clinical control. Now with isolation, access, and clinical control, I mean, you basically have to use a rubber dam when you do this work. Without rubber dam, composite bonded dentistry really doesn't last very long. And I think that's one of the big things we all skip is placing a rubber dam. And we're going to talk about rubber dam a little bit later as well. You need to have proper access and you need to have clinical control. Without moisture control, you're going to be in deep trouble and your fillings are not going to last. They're going to fail. So rubber dam and isolating is really important. The second critical step is caries and disease-free. If you're not going to clean a cavity properly, you're going to have a failure within the first year. And that's very important. So when looking at caries and disease-free, a lot of times we don't clean the cavity out properly. And there I just want to quickly talk to you about using something like a caries indicator or caries sable seeker, one of those materials. You need to use those things always when doing composite or bonded dentistry. You can get away with a filling that you didn't clean out properly if you're going to use an amalgam, because that's so bacteria doesn't like amalgam. All those toxic ingredients in amalgam make sure that the bacteria doesn't last very long. But composite is basically a plastic, and bacteria loves plastic. So if you're not going to make sure your cavity is caries and disease free, you're definitely going to end up with a failure. The third critical step is conditioning of the teeth. Now, I'm not going to talk to you on how to etch and bond properly. That you should know, and that's a basic thing. And you should always know that you can't use the same technique for all the materials or all the bonding agents out there. You need to make sure that whenever you're using, let's say, tetric N-bond or whatever bonding system you're using, that you know what that system is. Make sure you read the pamphlet that comes with it. Make sure you're etching and bonding for the right amount of time. And once again, that's one of the critical steps. So if you don't follow that step, you're going to have complications very early on and you're going to have problems. All right. Then we go into the next section, and those are the key steps. So the key steps, we look at preparation of the cavity, the matrix choice and adaptation, and also the composite placement. Now, when you don't do the key steps properly, you're going to probably have a failure within 1 to 5 years of your restoration. So preparation of the cavity is stuff like, are you beveling properly? Are you, when you're doing your class 4 restorations, are you removing enough of the undermined enamel? Are you opening up your proximal boxes properly when you're doing a class 2? So those are the key factors when doing preparation of the cavity. And I mean, all of these things we can talk about for ages. And when we do the online, the weekend courses, we go into depth about these things a little bit more. But these are key steps you have to follow. Matrix choice and adaptation. That's one of the very key things I think we miss. When your matrix choice and adaptation is not right, you end up with an open contact, or you end up with a leaking restoration. So using a Toffelmeyer is not good enough if you're going to do composite dentistry. You need to have a sectional matrix kit. You need to have the correct clamps. You need to have the correct wedges, and you need to know how to use them properly. So it's one of the key steps. You need to make sure you adapt your matrix band and make sure you use the correct one in the correct situation. One of the big mistakes we make here, and I found, is we end up placing too big matrix band into the restoration or the preparation, and then we have to do a lot of work afterwards to get the restoration back into the occlusion. If you use the right matrix band from the beginning, you don't have all those problems afterwards. So matrix choice and adaptation. And with adaptation, I just want to say you can take that thing and cut it if it doesn't fit properly. Make sure it fits properly around the tooth that you want to use. So take a little scissor and prep that thing and cut it away and make sure it fits properly. And make sure your clamp goes around properly and make sure you get a nice wedge in at the bottom. Right, the last key one is the composite placement. Now there it's just important, you need to know your composite. You need to know if you're going to do a bulk full composite, you need to use it appropriately. Don't go more than 3 or 4 millimeters. If you're going to use the layering technique, make sure you build up your cusps correctly and make sure you use the layering correctly. Don't use a layering composite and try and use it as a bulk full composite. It's going to work for the first year or two, and then you're going to get marginal leakage, you're going to get sensitivity, and it's going to pack up. So make sure you know how to place your composite, make sure you know what system you're using, and make sure you know your material properties as well. Then the last one, I call this the fun one, and this is called occlusal anatomy and polishing. So most of the cases, we spend a lot of time trying to get our anatomy, and especially our anterior teeth, we're trying to get all these secondary and tertiary anatomy right. And the patients don't really care about that. When doing composite work, the patients really care about 2 or 3 things. The one is it should be out of the bite. So this is the occlusal anatomy. You need to make sure it's out of the bite. You must have a good contact. If you don't have a good contact and food's going to get stuck in there, that's going to be a big problem for the patient. And the third thing is post-op sensitivity. So if you use these steps and you do these steps correctly, you'll have all those 3 things right. But a patient doesn't really care about what the fissures of the tooth look like, or what is the fissure stained or not. So that's important for us, and it's nice for us to put it on Facebook and Instagram to show people how fancy our restorations are. But a patient doesn't really care about occlusal anatomy and polishing. All they need to know is it needs to be out of the bite and it needs to be smooth. But all the other fancy stuff, we just do for ourselves, and we do it for our friends, and we do it because it's fun. Right, so those are the 7 stages of restoring the teeth as composite, and that's what I always try and follow when I do my composite work. Are there any questions maybe at this point?
No questions yet, Evert.
Stephne, or Paulo, don't you want to just put me as a speaker so I can just see myself? Sorry.
Okay, on the right-hand top side of your screen, you can select between speaker view and gallery view. Just
yeah, but you're the speaker, so I just see you the whole time. And
okay, so when you speak, then it will come up, your screen will come up. So whoever speaks will pop up as the main screen.
Really, okay, it's fine. It doesn't really do
okay,
it.
We've got one question from Helen.
Yes,
Helen,
right. It's not Helen, actually. Can you see me?
Oh, good morning, Mark.
That's all right. How's it, Evert? Well done.
Mark,
cool, man.
Are you even allowed to be here?
That's why I'm under the radar. It's Helen.
Yeah, you should be.
Using her device. Just a question, I think that a little bit of clarity. When you said that you leave them out of the bite, do you mean you leave them out of the bite, or you leave them in the correct bite? Not that they're high. So out of the bite.
No, yeah, sorry. Yeah, in the correct bite. I think. Yeah. I think the big thing is the big complication with composite stuff is it's always high, or not always, but that's one of the issues. So the correct bite and not out of the bite. Sorry, I probably said wrong there.
Okay. Yeah. Sorry. I just thought I'd get that. And obviously, looking at all the guidance, and especially if you're doing full mouth rehabs, I'm sure you'll get on
exactly. Yeah. Yeah.
Okay, I'll leave it then. Thanks so much.
Okay, we'll talk about the occlusal anatomy and finishing and polishing a little bit later again, Mark. I'm just struggling to see myself. Sorry, Stephanie. I've got it on speaker view.
And if you click at the bottom on participants, then all the participants pop up on the side.
Sorry, give me 1 second. I just want to fix this. Anyway, doesn't matter. Okay, so that's the 7 stages of restoring teeth. The next part I want to go to is the three very important considerations. Now, I just summed them up quickly into 3 parts. I think it's stuff we can talk about for a long time. And I think these 3 things, and especially 2 of them, will make you a better dentist immediately. And I just want to touch on them quickly. The one is rubber dam. I think rubber dam is the one thing we always tend to not, that's the first thing we skip if we feel we're under pressure, we need to work fast. And the excuses that I always ask people, why don't you use rubber dam? The excuse is always, I don't have time to place it. It takes too much time. And secondly, patients don't react well to it. And both those things are really, if you use rubber dam enough and you place it enough, it's really just an excuse. Rubber dam saves you a lot of time, and patients actually love rubber dam as well. So we're not going to talk about rubber dam a lot, and we're not going to get into it, but it's a completely separate lecture. But rubber dam is one of those things that's a little bit, I think, we're not using it enough, and I think dentists tend to skip over it. But it's a valuable tool that if you don't use it, we're going to get in trouble. What I want to quickly mention about rubber dam is I talk about three things when I talk about rubber dam. I talk about systemization, where you've got to decide what system you're going to use. There's a lot of systems out there. Ivoclar makes this nice Optradam, which I like. So just decide which system you like. The second thing is outsourcing. When I talk about outsourcing, I mean your assistant needs to know about the rubber dam as much as you do. So when you're ready to place a rubber dam, she needs to know exactly where you're going to go and what you're going to do, and then she needs to do all the preparation work for you. A lot of times we waste doing rubber dam is trying to prepare the rubber dam, where you've got an assistant that should be capable of doing that for you. And that's going to save you a lot of time. So what I always do, and that goes with systemization, is when I place a rubber dam, I always place it in the same way. I always place it on the 7, and I always open up the full arch. So like I said, it's a complete different lecture, but it's a very important thing that if you're not using rubber dam as a daily in your practice, it's really important that you do that. All right, we're going to go on to magnification and illumination. That's a second thing where I think if you do these two things, you would become a better dentist immediately. And doing bonded dentistry, you'll know without magnification, you won't be able to. And people that are not used to magnification doesn't know the benefits of using magnification, and especially illumination. I think when we look at magnification, we always think of loops or microscope or whatever, but that light we've got really makes a difference as well. So it's important to have a good light and a good set of loops. And the excuse people always give me here is that they can't afford loops, it's too expensive. Now, I've been using loops for about 6 or 7 years, and for about 4 of those years, I used eBay loops, which cost about 800 Rand. So cost is not an excuse. You can get loops for very, very low price. I would spend, if you've got the money, I would spend money on a good set of loops. We've got guys like Zoomax that gives you great service. And once you're into loops and into magnification, you'll find that you're going to want to get a microscope at some point as well. So it's one of those things. Rubber dam is the two things, rubber dam and magnification. If you just stick to those two things and start using them, you'll be a better dentist immediately. Okay. Then we're going to go on to dental photography. That's a third important thing I like to talk about. We don't have to be fancy photographers. We don't have to have fancy equipment. We can use something like the Smile Light from Ivoclar or Ivodent. That's an amazing product, but we need to take photos and we need to have some form of equipment. I don't think a cell phone is good enough when doing these cases. We need to have proper photography. And I want to quickly talk about that. Why do we take photos? First, it's for self-evaluation. I've been taking photos since the beginning when I started working in 2008. And it's nice to go back to those photos and see the work you did and see the mistakes you did and see how you can learn from those mistakes. I'll show you a case that I did in 2015 and the one I did more recently. And it's nice to see the difference between the two, to see how my work is getting better, hopefully, and how it's changing. So it's important to have it for self-evaluation. The other thing that's important is for lab communication. We use the eLab system in our lab, which is it's a system that they can use to do proper color matching, color shading. That's something to look into. The other thing in lab communication is a lab sits there and they get a model and you ask them to do 6 veneers or 8 veneers or whatever, and they've got nothing to work with. So you need to make sure you get them proper photos, full face photos, full smile photos, so they can work properly. And obviously Smile Design, Mark, you know the value of Smile Design. It's an amazing tool to use, and without proper photography, you won't be able to do proper smile design. And so that's another reason. Record keeping, a picture is worth 1,000 words. I mean, having pictures of all my work dating back to 2008, it's amazing to see how my work is kept up and how it's failed. And also for medical legal things, if there's a problem, you can always just pull up your photos and you can look. You can't lie in a picture, so it's very important to take pictures. Just on that topic quickly, I had a lady that came to me after she went to one of the dentists in our practice, and they did some composite veneers for her, and she wasn't happy with the work. And I said to her, well, let's just look at the before and afters. But there were no befores taken, there were only afters taken. And if you end up with only after photo and no before, it's difficult to show the patients how far we've gone. Maybe our work isn't always great and always amazing, but if you can show a before and after for a patient, it really goes a long way. So it's important for record keeping. And obviously marketing as well. We spoke about the Facebooks and Instagrams and those kind of things. And when patient logs onto your website or your social media pages, they want to see your work. They don't want to see Mark's work or someone else's fancy work. They want to see the work you're doing, because that's going to instill some confidence that you can do the work well. So it's important to take good photos. And like I said, photos and photography is a massive thing, and there's a lot of good courses on that. And if you want to get into it, it's really worth getting into it. But I think the basic thing is you can't use a cell phone. You need to have more and better lighting, and you've got to spend some money on photos and spend some time on photos as well. Okay, so I want to quickly just go through those things and just say why that's important for me. So the next topic is tooth morphology. Is there any maybe questions before we go on?
No questions yet, Evert.
Right, so tooth morphology is a thing that kind of eluded me for a long time. Until recently, the work I did was always very flat, always very dead. You didn't really see a lot. And as soon as I got into it a little bit more, and actually it started with doing smile designs, I started looking into more morphology and what can I do to make my cases look better. And I started seeing things that I never knew before. I started seeing the line angles and the incisal and the gingival embrasures and all these little things that I never knew and never stood out for me. And then as soon as you start to know these things and notice these things, you actually get better with them and you start wanting to learn more. And I'll show you just with two cases that I did. The one case on the left-hand side is a case I did about 5 years ago. And you can see the patient was super happy with that work, but you can see it's not really great. I mean, everything is flat, everything is dead. It looks average, but 5 years ago, I thought it was pretty nice. The patient thought it was pretty nice. And the patient still comes to me every year for his checkup. He lives in Botswana. And every year I tell him, listen, we can get these things to look better. And he says, I love it. I love my teeth. So just keep it the way they are. The case on the right-hand side, you can see I spend a little bit more time in anatomy, trying to put more morphology in anatomy and get the line angles a little bit better. And this patient is actually my neighbor, and I see him on a daily basis. And if you look at that teeth, you probably think, that doesn't look that great. But when you see the guy smile and you see the guy talk, it just looks amazing. It just looks like natural looking teeth. And that's the important thing about knowing your morphology, knowing the line angles and the angulations of your teeth and like I said, the gingival embrasures and incisal embrasures. And that comes with doing a lot of, that's just the things I like to use when learning about morphology. The one is called Nature's Morphology. It's a book that I stole from my lab, actually. Hopefully he's not hearing because he's probably looking for it. The other one is called, it's like a coffee table atlas by Aman Gerbach. It's actually available from Ivodent. And that's a nice pictures of anatomy and morphology. And then I used the DSD skin set by Paolo Cano, which is a 3D models, printed models. And it's nice to have in your hand, and I've got one here, and just to look at the different angles and the different sides of teeth and just to learn your morphology. And then the last thing I also use is the Essential Lines by Style Italiano. Essential Lines was done by Giuseppe Giudora. He's an Italian dentist, and he made these essential lines and essential shapes. And essential lines are the basic lines you have to put in your posterior teeth to give it a good anatomy and good morphology. And the essential shape is the front teeth and give you a primary and secondary and tertiary anatomy. And that's things you should start out with and play around with and try and incorporate in the work you do. And the easiest way to incorporate that is to use wax ups. And now for a long time, I didn't use wax ups, and my lab always told me, listen, you should start using wax ups. And recently I started doing wax ups, and it's amazing to see how your work gets better. Now, when you look at wax ups, we can see the manual wax ups and the digital wax ups. That's the two ways of doing a wax up, and we'll all tend to want to go the digital route, but there's some value about doing manual wax ups and manual work. And I like, when I do my own composite veneers, I like to take wax and maybe take a bottle of wine and just spend time and do the wax up the night before I do the case. Because the cool thing is you kind of learn the line angles. You can see where you want to go with the case. You can see what you want to do. You kind of learn teaching your eye and teaching your hand doing these stuff. A digital wax up is an amazing thing, and it's very quickly to do, but you're not really learning anything if you send it to someone else to do. So if you want to do composite, anterior composite work, and you want to do it freehand, you want to do it by yourself, it's always nice to use some wax and start doing your wax ups and playing around with it. The digital wax ups, like I said, when you're going to start getting into what are these things? When you start getting into injection molding techniques, which is very popular, and smile design using the injection molding with composite, it's a very nice thing to do. But if you're going to do it freehand, you're going to do it yourself, try and do the manual wax up. Otherwise, if you're going to do injection molding, you can do the digital wax up, and it's an amazing the results you get from those things combined with a smile design or something like that. Right, so I'm going to move on to composite veneers. Is there any questions on wax ups and the way I do them, or?
Yeah, but we don't have any questions as yet. Dr. Ibrahim actually just asked where he can find the essential lines. So the guys can just pop onto Style Italiano's website and just look under their library. They'll be able to download it.
Yeah, they actually don't. To get that, those it's cards, and Mark will probably help you with that when you do his course. They'll probably give it to you, but you can't give it, or they don't give it away if you didn't do a proper Style Italiano course. So that's where you get them. You'll probably get them from Mark's course, those essential lines. Mark, you can just let us know if they're available at your course. But it's a very handy little tool. And I showed the anterior one. The posterior one is actually more handy when you use it for your occlusal anatomy.
Yeah. There we go. Mark is giving us a heads up. They do get it at his courses as well. If they also look on our YouTube channel, John van Leerop covered posterior composites last week, or more just the matricing and the instruments. And there he also covered the posterior essential lines.
Great. Like I said, this is basically an overview of everything I use. So to get into more details, there's a lot of amazing courses like the ones Mark and John is doing. So I think, and Mark, you can jump in at any time if you want to, but I think composite is just such a nice tool to be using at the moment. We should explore all the options, and someone like Style Italiano is making available amazing resources and amazing cases that's being done in composite. And I think that's why composite is so relevant at the moment, and I think we should be paying attention. Right, so composite veneers are the one thing the patients come in for and want, and that's one of the things that we can offer them at a good price and give them very good value for money when they come in. And there's three ways of doing composite veneers. The one is injection molding, and recently injection molding has become very popular. It's become very, I think, especially with companies like GC, they're pushing it quite a lot. And it's a nice technique to use. I don't like it that much for a few reasons. The main reason I don't like it is because as soon as you use the injection molding technique, you kind of lose your clinical access and your isolation. So I'm always worried that what's going to happen to my margins where that's kind of subgingival or equigingival. I'm not sure if I can isolate them properly and if they're not getting contaminated by the sulcular fluid. So that's my one problem with injection molding technique. What's nice about it, you can do the wax ups, you can do a nice smile design, and you can get a very nice case. In this case, you can see the teeth are very flat. I flattened them down slightly to get the occlusion right. Otherwise, I didn't have canine guidance and I might have had some problems. And the second issue I do have with doing these injection molding stuff is cleaning it up afterwards. You can see this case the photo was taken right after we did the case. And I really struggled to clean out interproximal and make sure there's no overheads and overhangs and stuff. And like I said, my clinical access and clinical control is very difficult in using this technique, but it's an amazing technique, and it's one I use quite often at the moment just to get better at it. And we can go through the steps. I don't think we have time to go through everything now, but there's a certain way of doing these things. What I just want to mention quickly is you don't have to have something like the GC injectable composites. I use a normal your normal Ivodent Ivoclar composite. I heat it up, and then I use the heated composite in my molds. And the extra clear is the product from GC, but I use a product called Transil from Ivodent. It's much cheaper and it does the same thing. It's not as clear. The Exaclear is a little bit clearer, but it's exactly the same product, and it's way cheaper than using the Exaclear. So these things are very nice tools to use, and it's nice things to play around with, and it's definitely something you should have in your box of tricks to present to patients. Once again, my issue with it, I can't isolate properly. I'm not sure if I'm getting any contamination in there. And secondly, I struggle to clean interproximally. So those are the issues. The next one is wax up and stent. So this is not a picture I took. I didn't have any nice pictures of a wax up and stent, but this is just a nice way if you're going to do bigger cases. It's nice to have a wax up from the lab and then use that lab and make yourself a little stent, and you can fill in the blanks there and just do the composite. Once again, this one you can isolate properly. You can be sure you can place a matrix band in there, and you can make sure about your isolation and clinical control. So it's a nice one to use. The last one, and the one I use mostly, is doing it freehand. What I like about doing it freehand is you the artist in this case, you can play around, you can do your things, you can add up, you can take away. Secondly, it's way cheaper to do it this way. You've got no lab bills. If a patient walks in, we get a lot of patients from abroad or from far that's only here for a holiday and they want something done. Maybe a patient that got a holiday house down in J-Bay, and you've only got a few days. You can do a composite freehand for them, and they normally very happy with it. Once again, if they're not happy, you can change around and play around with it. So I do a lot of composites freehand. If you're not going to change angulations or change the shape or do big things, you can do it freehand pretty well. And once again, that's what I use to do my isolation. I use a normal matrix band. I'll just show you the normal Toffelmeier matrix band, the old school ones. I started using them before the Unica bands came out. And the problem I have with the Unica bands, I struggle. They're quite soft and they're kind of bendable. So I use this Toffelmeier band, and they're quite hard. And then I just place them like I showed there. I place them over the tooth. You can do it with a rubber dam, without a rubber dam. But you know, when you place it in there, you can get good isolation. You can see in there with your loops and shine your light in there. You've got no sulcular fluid or just contaminating your site. And you can then just prepare your cavity properly. Once you've done that, then you start with placing your composite. So I keep my bands on. I place the composite. I get my primary anatomy, and I just take a little. I take a little brush and I just brush it in there. It's amazing if you start using these brushes. I tend not to use a lot of wetting agent. I'm not a big fan of it. I like to just get my filling or my restoration polished with a little brush, and it just gives you a nice, just brings out that the resin in that composite quite nicely and gives you a very nice finish if you use a brush. The way you use the brush, you apply very softly and you just brush over and over and over and over, and you end up with this very nice glossy appearance. Obviously at this stage you want to put your primary anatomy in. You want to make sure your anatomy is in the right place. The secondary and tertiary anatomy you put in later, but at this stage you just want to make sure your teeth are in the right place. You want to bring in your line angles to the right place, and then you want to polish it properly. And then another tip or trick at this stage is when placing your composite is, especially the final layer, if you do 2 or 3 layers, the final layer needs to be one layer that's packed in there. You don't add on to it. As soon as you start adding on, that's where we'll get little cracks, and that's where the filling would leak, and in a year or 2 or 5, you'll end up with a little black line there. So try not to get bubbles in there, and try not to get any layers. So pack it in one layer, press it in there quite firmly, and then you can polish it off. So that's how I do my composite veneers, and the 3 ways of doing it. I think obviously each of us should find a way that works for them. Like I said, in my hands, I enjoy the freehand stuff. I enjoy not having to work with a lab. But as soon as you get into digital smile design and you want to do those kind of things, then you want to go the lab route. Obviously, it pushes up the cost a little bit, and you should be sensitive to that. But that's a very nice way to do your composites as well. The next thing I want to talk about is the vertical dimensions. Should we wait for any questions, or can we go on?
No questions, you can go on.
So when doing the vertical dimensions, I think it's a quite a touchy subject, I would say. I think a lot of dentists are scared of opening up the vertical dimension. And I'm not sure if we were taught way back that we shouldn't be messing around with the vertical dimension. But I think as soon as you start doing it and you start getting confident in it, it becomes a lot more predictable, and you'll see that people are more open to it. As soon as you change it, people are very uncomfortable in the beginning, but as soon as if you give them time and you make sure your basics are right, then you get a good result. So I want to go through those steps on how I do it. So this is the case we did. You can see the wear facets on those lower teeth. And in this case, we open up the vertical dimension. So I'll just show you quickly how to open the bite predictably. There's a couple of things you have to look at. The first thing I always look at is the Shimbazi number. Now the Shimbazi number, I'll quickly just go down, is that number from the gum line of the upper to the gum line of the lower. So the cement to enamel junction from the upper teeth to the lower teeth if the patient bites down in occlusion. Now, what the Shimbazi number is, it's 19 millimeters plus or minus 1 millimeter. So if you've got a patient and you bite down and you measure the Shimbazi and you see it's 10 or 11, you know you can predictably open the bite quite a bit before the patient is going to be in trouble. Now, I tend to make it a little bit less than that number. I've done a few and I always measure the cases, and it always ends up maybe, I would say rather 17 plus or minus 1 millimeter. So let's say I've got a Shimbazi number of 11 or 12. I would comfortably open up with 4 millimeters, and that'll be a good starting point for me. And then you kind of, the next step is you kind of thumb suck it. So I get the Shimbazi number, I open up the bite with composites on the lower teeth, and then I ask the patient to open up and close and open up and close. I kind of see the movement of the jaw. I look at the clicking of the jaw. I see if it's a non-reducing or self-reducing type of mandible or TMD, and I see where it goes. And this is looking at the jaw is always a nice thing to kind of guide you. The next thing I always use is an equalizer. So an equalizer is a thing they use in orthodontics. So it kind of gets the jaw not just in 2D movement, but you can kind of move it 3D, because the jaw is not just a 2D scharnier, it moves in more ways. So if you've got more wear on the one side, the jaw would be opening up like this, but sometimes the jaw actually wants to open up. So what it does, the equalizer, it's got a little bit fluid filled, if you don't know what it is, and when the patient bites on it, you can get that movement better. So I give it to a patient for 3 or 4 days before we do any work and let them then sleep with that and see what the jaw does. And it kind of is a nice little tool just to bring out those sideways movements. And you obviously got the leaf gauge, so we all know that we can add on to the one side or add to the other side and see where the jaw is going. And then it's always important, when in doubt, always temporize. Now, like I mentioned in the beginning, that's the nice thing about composite, is it's kind of a very long-term temporization. And when in doubt, if you use a composite to open the bite, you can always add up or take away or anything. And that's especially if you're going to open the bite for 5, 6 millimeters, which in some cases you do. You're going to have to be aware that sometimes you're not going to be right, and sometimes you want to add on and take away. And that's why I love doing it in composite these days, and especially using the tetric CAD blocks, where I can actually play around with it a little bit. And then I tell the patient, if we've opened the bite and we've opened it quite big and we see, okay, let's see how it goes. And I always leave the patient 2 weeks before I get them back, because in those 2 weeks, a lot of things can go wrong. And they probably think something is not right, but you need to leave them at least 2 weeks for them to get used to the new occlusion and used to the new bite before you start fiddling around with it. So the different ways of opening the bite, you can obviously use orthodontics. Stephne?
We've just got a quick question, just to pop on the Shimbazi number again, just your previous slide.
Okay. Should I just keep it there?
Yeah. And you said it must be 17 plus minus 2.
Okay,
right?
so it's according to the paper that Shimbazi, the guy's name's Hank Shimbazi, the paper he wrote is 19 plus minus 1 millimeter. So you can go 19 millimeters or 20 or 18. But I found if you measure a lot of patients, it tends to be a little bit less than that. So I kind of stick to about 17 millimeters, my guideline. And that's just a kind of a feel-good number that you can work up towards. So it's kind of just a starting point to start off with.
Thank you. That's all.
All right, and then how to open the bite. There's obviously a bunch of different things. You can use orthodontics. You can use the Dahl principle. I think we all know the Dahl principle. We do the front 6 teeth and let the rest of the teeth overlap. You can use freehand, where you build up the teeth freehand with composite. You can do the wax up an injection mold, or you can use CEREC. And the way I kind of like to do it is I kind of always stick to the wax up or the CEREC. So the wax up kind of just gives me that confidence of where I'm going, and using the injection molding technique then in a wax up is very nice because you get a good result. And always the nice thing about doing these posterior cases and these wear cases, because most of the cases I see is older people or younger people get it more younger now these days, but they've got a lot of wear on the lower teeth and you want to restore those 2 or 3 millimeters, and it's not subgingival. So using the wax up technique is a very nice technique, and you can get quick results, and it's, for me, easier to use it on the posterior to open the bite than using it in anterior. And then you can use something like CEREC as well, where you do inlays or overlays. And when I do these, when I open the vertical, I always stick with, for the past year or so, I always stick to the tetric CAD blocks. I don't like, especially if I'm uncertain, I like to use the tetric CAD. And then I explain to the patient, this is a long-term temporary solution. We're going to see how it goes. We're going to leave it for the next 2 or 3 or 4 or 5 years. And just getting back to that treatment planning is, we are phasing the treatment and we are delaying the treatment. If I'm not 100% sure about the occlusion, I'm not going to try and stick in something like a EMAX or a hard material index. It's going to firstly either break or it's going to be very uncomfortable for the patient. So something like a tetric CAD block kind of wears very nicely, and the patients are just more comfortable when you use that. But once again, I state to them that we're phasing you into treatment. We don't have to go into fancy lithium disilicate stuff. We don't have to go into lab stuff. Let's see how it goes. And like I said, the more I do these things, the more I realize these things actually last very long, and patients get a lot of mileage out of them. And if I see it doesn't work well, a year or 2 down the line, we get fractures or we get something, then I look at something else. But if a composite is going to fracture, the occlusion is wrong. It's not the material that's wrong. So rather fix the occlusion. And that's the nice thing about composite. You can fix them, and you can fix the occlusion by taking away or adding up. Right, so that's opening the vertical dimension. Is there maybe any questions that I didn't answer, or maybe anyone want to add on to that?
Not yet.
Not yet.
No questions. Right,
then the last stage I always do is finish and polish. And when I do these cases, I always get the patient back a week or 2 weeks later. If I'm going to do a full mouth case and I'm going to open the vertical dimension, I'm not going to get them back for the first week. I'm going to get them back 2 weeks later. So I want to give them time to firstly get used to the bite before I get them back. Sorry, that's just a photo of the fusion where we open the bite in this case. On the fourth quadrant on this side, we use CEREC overlays with tetric CAD blocks. On the other side, I use the injection molding. And it's just interesting to see the difference. I'm a big fan of CEREC, and I think it works very well in these cases, but you can just see the difference between the wax up done by ExoCAD and the proposals given by CEREC. The ExoCAD, it just looks way better. So I'm leaning more towards the injection molding side at this stage. The material is exactly the same. It's tetric Inceram or tetric Evoceram, whatever they call it. The one is in a block form, the other one is heated, and the injection molding form. So the patient, it's exactly the same product, but I tend to lean more towards the injection molding side when I open up these bites than the CEREC. And the nice thing is you don't need the CEREC machine to do these cases. Right, so finishing, polishing, there's a couple of things I look at. We're looking at the anterior teeth. At this stage, I want to get in my secondary and tertiary anatomy, and I want to make sure all the things bother the patient, I'll fix at this stage. I don't try and finish the case immediately. Ask the patient what bothers him, because after a whole day of working, you're getting tired, your eyes are tired, you're seeing things you shouldn't be seeing. It's always good to give it a break, let the patient go home, ask their significant other what bothers them. If you've got a little bubble, anything, fix it at the second appointment. So make your time for the second appointment nice and long, so you can fix all the issues, and you can also do proper photos. So at this stage, I look at the line angles. I use the little instrument, Optrosculpt from Ivodent, to draw in my line angles. I do my secondary anatomy. I do my polishing. I like the Eve polishes. You see there to polish the teeth. I always use them. And then at this stage, if there's a bubble, I'd fill in a bubble. Now the way to do a bubble is to open it up completely, and then you put your silanate the area, then you bond it, and then I put a little bit of flowable in it, especially if it's a very small bubble. I fill it up with flowable all the way, and then I cure it, and then I polish over that. And normally you get a good result when you fix a bubble like that. Like I said, I draw my line angles in with a pencil, and I just take a fast handpiece and I just cut them out, polish them nicely, ask the patient what bothers him, and there is my final result for doing these things freehand. In this case, I also look at, have I got canine guidance? Is there any occlusal interferences? After 2 weeks of opening up the bite like this, the patient would normally tell me if there's really a thing that bothers them, and I would fix that, and I would sort that out. And like I said, I always mention to them, especially when opening up the bite and doing these overlays, that this is long-term temporaries. So we're going to see for the next 4, 5, 6 years, we're delaying the treatment and we're phasing it. If we need to, we can work on that. But like I said, the more I do of these cases, the more I realize these things actually last very long. You actually get a very good result, and we don't have to do a lot of occlusal changes. And at the same point, it's costing the patient way less than going for the porcelain route. Let me just see. Yeah, that's about it. Is there any other questions I didn't answer?
Yeah, but good morning, Paul. We've just got a question here from Dr. Bodenstein. How do you manage the interproximal areas posteriorly with your injection molding?
Okay, so basically what I do is, I've got some slides that I show, is I always, with the interproximal area, I always, if I've got a contact that's open, let's say a normal typical class 2, I would use my interproximal band and I would build that up. So I'd build it up to the occlusal level, like a normal class 2 restoration. So I'd use the interproximal, the sectional matrix, I'll clamp it, I'll place my first layer. Then I'll only use the injection molding for the top layer. So basically the top 2 or 3 millimeters. So you get a good contact point and then you build up the tooth. Does that answer your question? Is that?
I think that's great. Paul, if you want to add or take part in the discussion, you can unmute yourself and ask Evert the question directly.
I hope that answers your question. It's always still important that you get proper contacts, because like I said, that's one of the things that bothers most of our patients is not having a good contact. So you need to get that contact right. Then obviously when doing your injection molding, you should separate your teeth from the other ones. You don't do all of them at once. You separate your teeth. You use your plumber's tape in between the teeth and isolate them properly, and then bond it and then place it. Okay, but interproximally you still kind of struggle sometimes. But if you do it properly, you use your PTFE tape properly, separate it, don't get bonding on the other teeth, then you get a good result. Does that answer the question? I hope so.
Yes, thank you.
We've got one more question here from Michelle. How do you try to ensure longer term results for patients with wear bruxism to ensure that the composite doesn't fracture easily?
Okay, I think the important thing is, like I mentioned in the treatment planning, I always give my patients a Michigan splint to sleep with. I don't do a soft pullover splint or a suction splint. I make a acrylic Michigan splint. That's the one thing I use. But also, if your occlusion is right, you tend to have less problems with fractures and things breaking. So always make sure you get your occlusion right, and always make sure you've got your canine guidance and your group function, and make sure you've got all those things in place that it won't break. And then if, let's say you've got a tooth that keeps on breaking, then you know the occlusion is not right. You need to go back to the occlusion and fix that. I don't think throwing in a stronger material is necessarily the answer. I think sometimes it's better to have a weaker material so that the material can break instead of the tooth breaking at the bottom. And like I said, we see so many of our patients 75 years old and the whole mouth is falling apart because the crowns are still fine, but everything else underneath is not there anymore. They can't afford now to get these implants and big rehabs done. So I always, like I said, I would rather let my filling fracture than put a fancy crown and a post on there and then have the whole tooth break 5 or 10 years down the line.
One last question, Evert, from Dr. Kotze. He's asking, do you bevel palatally with a class 4 restoration or only facially?
I do palatally as well, as a functional bevel. So I always give a palatal bevel. Not as deep as the aesthetic bevel, but I do give a palatal bevel. Yeah, and you just get a little bit better bonding. So you don't go through the enamel. You just have like a 45-degree bevel, I would say.
There we go. I don't see any extra questions popping up. Guys, if you have a look on the screen, please be sure to follow Evert on Facebook, Instagram, and YouTube. He does post quite nice cases and also some exciting lifestyle photos of all the adventures.
Yeah, so if there's anything else, please send me a message personally. I'd love to answer it. If you think I'm talking nonsense, also please, I'd love to learn as much as you guys from doing this. So please send me a direct message or phone me or whatever. We'll have a discussion. We've got a lot of time on our hands, so we can do these things now.
There we go. Guys, to bring it to an end, if you have any topic suggestions for our lockdown sessions, please email info@ivodent.co.za. Catch this session to rewatch and all previous sessions on Ivodent SA's YouTube and link on Facebook and our WhatsApp groups. If you want to be added onto the closed WhatsApp group, please send your cell phone number through to info@ivodent.co.za. This week, Thursday, 23rd of April, same time, same place, 11 to 12 o'clock, our senior dental technician, VENEERS, will be sharing his knowledge and expertise with the versatility of laboratory composites. Not just creating gums on a hybrid abutment implant bridge, but also characterizing a denture with veins and stippling that not even you and I will immediately see that the patient is wearing a denture. True art in its finest forms. Lastly, before I switch over, I just want to share, I can't share my screen. I just want to notify you all that we do have face shields available. They come in packs of 5. We do have limited stock, so if you guys are interested, please send an email through to orders@ivodent.co.za. Evert, bye-bye, dankie vir jou tyd. With our current economic circumstances, I can only see this treatment modality becoming increasingly popular. Composite is an extremely adaptable, predictable, and repeatable product of choice. It is forgiving and ultimately repairable in the mouth. Bye, dankie.
Thanks, Stephne. Thanks for having me. Have a lucky day.
You guys must all have a lovely day. See you Thursday.